So this is part 2 on living with long COVID, hypermobility, and EDS. I was just looking at this amazing chart, which is from Disjointed by Diana Joven, and this is in the Maxwell dysautonomia section. Dysautonomia, the most common type, of course, is POTS. So pre-diagnosis, we basically want people with EDS to know that they're more prone to POTS and to take some lifestyle modifications to help prevent POTS. This is the trifecta. So we've got hypermobile Ehlers-Danlos syndrome, POTS, MCAS, and they all have these overlapping symptoms right here in the middle. These are going to be the things that I'm looking for in my long COVID group. And then we also have the symptoms that are a bit different. So these are more prone to be just for MCAS. These are more prone to be just for hypermobility. These are more prone to be just for POTS. So I use those for some of my screening questions when I'm talking to people. So pretty quick into long COVID therapy, I realized I was seeing a lot of hypermobile people. So I started screening for that very quickly into my work as a therapist. And I did not wait for the research to come out. It doesn't hurt for me to screen people. I would say of the young women I have, it's a very high number that have joint hypermobility. It might be as high as 70%. And then with the long haulers that I see overall, I would say about half of them have joint hypermobility. It is not supposed to be that common in the population. So I'm not the only one that noticed these partners right here. Gez Mendinger, is a big time long COVID advocate. They are working to find what might be going on with this. This study is not out yet, but we also, that's posted already on the Ehlers-Danlos Society. So I'm not the only person that's noticed this. And then just in the last few months, we've had a lot of really good research come out saying the same thing. So this was from a pre-publication. It has since been published and peer-reviewed. So know that this has been picked up by a medical journal and been peer-reviewed, but it's basically saying, hey, I think that there's some common genes with Ehlers-Danlos and with these long COVID symptoms. So here are the genes that are implicated in terms of long COVID or COVID-19 severity and then EDS. So please check out that resource. Next up, we've got basically, hey, I had long COVID, but it turns out when I got screened, I actually may have Ehlers-Danlos or hypermobility spectrum disorder. And again, this is what I've been seeing for a long time. So I'm so glad to see this publication. It just came out a few months ago. And they're basically saying, hey, these symptoms are very, very similar. It's associated with POTS. That's very similar. And we will see this predominantly in the younger female age group. And then we've got this other paper that's basically saying, do people with ME/CFS and joint hypermobility represent a disease subgroup? This was a registry data analysis. And the conclusion is that ME/CFS patients with joint hypermobility, especially those with EDS, basically have distinct clinical characteristics. They have more severe symptoms and they have more reduced quality of life. So this is, again, just as I'm saying, very, very common, and you can find that information right here. So how am I treating this as an occupational therapist? I definitely want to do a little bit of a case study with you. So I'm going to have to flip my, So we've got the case study, the case of the high school swimmer. And slideshow from current slide. All right, so I don't have every single piece of information on here, but the case study, the case of the high school swimmer, she came to my long COVID clinic, young female, so already had some red flags there that she might be this EDS subtype. Her primary complaints were light sensitivity. She had brain fog, migraine, daily migraine that had been ongoing since she had COVID, dizziness, and fatigue. So some of the pros are that she's young and she had a lot of support because she was still living with her parents. The cons, her mother is chronically ill, so dad was kind of spread thin. And then, of course, that's a chronic stressor. And then it's actually really hard for me to rehab former athletes because they always want to push through. And we know with ME/CFS, the opposite of pushing through is what we need to do. So I actually always put that in the con category whenever I'm working with somebody. And then because she's young, she wanted to do it all just like she was used to doing and her peers did. She was already on a lot of meds when I saw her as well, and I had a feeling some of those meds were not medically appropriate. And then also she lived 3 hours away from the long COVID clinic. So I basically saw her once a month, and we're going on 14 months now. So this is somebody I'm still seeing. So when I assessed her, what we're looking at is that she had moderate disability. She was positive for post-exertional malaise. I also screened for hyperventilation because that's really common with this population. She was positive for that as well, so her breathing was completely off. She was positive for dysautonomia, POTS. I did an active stand test on that. And then I also had her take a symptom questionnaire called the Compass 31. And then when I did a physical examination, she had both of her eyes were dilated, and that's a big red flag for dysautonomia. And then she also had an nystagmus. That means that her eyes were having difficulty controlling their vision patterns, so there's like a little bit of a shake. She was definitely hypermobile. She was 9 out of 9 on the Byton. Dad is also hypermobile, so we know where she got it from. Genetically, there's a link there. And then upper and lower cross patterns, that basically means that her posture on both her hips and then her upper shoulder girdles were really off, where she's over and under engaging in a cross-like pattern. And then I basically found out that she had undiagnosed TMJ and then upper airway issues. So some of the things that we saw, what did I do first? I always want to get people with that post-exertional malaise first and try and get that managed as much as we can. So they laughed at me at first when we talked about reining in her activities, but I really continued to discuss and emphasize pacing principles. And I got her on the Visible app, and that showed when she contracted COVID again before she even tested, because her scores were going down. And she already knew the pacing strategies and how to avoid making symptoms worse. Because she was having so many eye symptoms, and that's very irritating for your brain, we really needed to work on controlling that. So her eyes were continuously dilated, and that makes her more prone to light sensitivity. So tinted glasses are a good way to kind of help with that, but also not overcorrect. And then I made sure that she was taking lots of eye breaks, and we got her on some eye exercises to try and help with that nystagmus a bit. Now, because she was 9 out of 9 on the Byton, I knew she was hypermobile. So we basically got her on a hypermobile POTS and strengthening protocol right away that was appropriate to her, and it wasn't overdoing it. And then we discussed all the lifestyle POTS management and positioning and modifications. I've got a really good YouTube on here that's about 15 minutes long. That I will link under the POTS information once I get it up, or you can just look at my videos and find it. So we did all of those interventions for her. We did the active stand test, and basically we were showing that the medications that we were on wasn't correct because they were lowering her heart rate, but then her blood pressure was also going down the longer that she stood, and that's not what we want. So that was probably contributing to her headaches because she wasn't getting enough blood flow to her brain. So I helped work with her providers to get her on more appropriate medications. That's still something that we're working with. And then this one is a little bit off screen, but people that hyperventilate, they can only do the right kind of breath work. So we made sure we got her on the right kind of breath work, which doesn't flare her hyperventilation, and that helps with her core strengthening and then also feelings of anxiety. Okay, and then this is also cut off, and I apologize for that, but that undiagnosed TMJ is a big deal. As we know, basically that jawbone can go back and actually physically hurt that the vagus nerve, and we want that to be functioning stronger more now than ever. She was on Botox because of migraines, but what we know with hypermobility is that we don't want to weaken your existing muscles. So that's not an appropriate treatment for her. So it wasn't really helping. It wasn't reducing her headaches anyway. So I, was like, hey, is this something that we can basically get off of? I also started her on sleep apnea and airway exercises. And then we talked about how to manage her TMJ. She did a sleep study, and basically it's showing that she is having upper airway breathing issues. And so I had her check out an airway-centric dentist who works with sleep apnea and TMJ. They did all the imaging and the right tests, and she was diagnosed with severe TMJ. It was just on the right side, and she also had a severely deviated septum, so she wasn't breathing well through her nose, and then that was affecting her neck. So she had a lateral cervical curve that would, again, even more likely to impinge on that vagus nerve. So those are all the things that we did in order to help this patient. I made sure that she was really getting a good thorough physical, that she was meeting with the right specialist, that she's appropriately medically managed. But you see all those different interventions, and that is a lot of things for her to be doing on the day-to-day. So this is not an easy thing, an easy road, but at least she was receiving appropriate management. And I gotta tell you what, the dad and the swimmer, they don't laugh at me when I'm talking about her symptoms and how to treat it anymore, because I basically had her on correct protocols prior to diagnosis. And over the last year, she's been making big steps forward. So again, neurology saw her before me, and it took them a year after me to diagnose her officially with dysautonomia. They didn't give her any lifestyle modifications. So the fact that we had her on correct protocols for 1 year prior to diagnosis is a really big deal. Also, and again, this one's off, but they basically found out that she had hypothyroid, and that can also cause dysautonomia symptoms. So she's now under treatment for that. And then because she is this hypermobile type, she basically, I screened her for pelvic floor issues, and then they assume that she likely has issues with MCAS. So that's kind of next up on my agenda. So I wanted to share the resources here. ellersdanlos.com. Living Life to the Fullest. That's the book that I showed with the exercise protocol for if you aren't feeling well. Disjointed by Diana Joven. If you are having medical issues and you're hypermobile, is the book I recommend. Too Flexible to Feel Good. That is a great one if you are a pretty well zebra, because it just talks about positioning and some of the lifestyle things that you can get started on early on. If you want to search for a PT who knows about EDS, I really recommend using these things right here. I'm not registered though, and I'm an OT that knows about EDS. So word of mouth is another good thing. And then these are the resources that I used in my PowerPoint. So thank you very much for listening. Let me know if I missed anything.